Polycystic liver disease is a mostly hereditary disease that often, but not always, occurs along with polycystic kidney disease. The main problem is unrelenting growth of the cysts with compression and functional impairment of the adjacent organs.
Polycystic liver disease is a rare disorder, but in a minority of patients, symptoms will arise. So that is why you need to know how to manage these patients.
The prevalence of the isolated form of polycystic liver disease is 1 in 10,000. However, polycystic kidney disease has a prevalence of about 1 in 1,000. And almost every patient will also develop liver cysts. 80% of patients are female, and cysts are rarely observed before adolescence.
Polycystic liver disease probably results from biliary malformation. We know that the majority of patients with polycystic liver disease have a genetic mutation. In case of ADPKD, mutations in PKD1 and PKD2 will cause the disease in the overall majority of patients. And experimental evidence suggests that in those patients, the level of polycystic 1 is actually decreased. And it is being reasoned that this actually is associated with the onset of cyst in those patients.
Biliary malformation results from increased proliferation of cholangiocytes in combination with fluid secretion. This leads to formation of multiple cysts and liver growth. However, the function of the liver remains unaffected by cysts. If there are more than 10 cysts in the liver, the diagnosis of polycystic liver disease is made. In advanced cases, the entire liver may be riddled with cysts. Female gender is the strongest factor associated with the risk of a severe course of PLD. 80% of patients in cohort studies are female, although PLD is inherited in an autosomal dominant manner. The use of estrogen-containing preparations is associated with a larger liver volume.
We've actually compared patients who use oral contraceptives for over a longer time compared to patients who did not use oral contraceptives. And we found that patients who do use oral contraceptive have an increase of liver volume of 15% over the course of 10 years. So in our outpatient clinic, we actually advise patients to stop taking oral contraceptives. Patients will present to the outpatient clinic when they are in their 30s, 40s, mostly after a first or second pregnancy. In most patients, we see a small increase in liver volume year by year. And that can go on to menopause. After menopause, we see that the liver volume in these patients actually stabilizes and that patients will develop less complaints than before.
The liver can grow up to 10 times its normal size during the course of the disease. But synthesis and detoxification function of the liver is maintained even in advanced cases. However, large liver volumes lead to symptoms due to mechanical pressure on adjacent structures. Typically, there is a feeling of pressure or fullness, and also restricted movement and pain, especially when bending or sitting. During the course of the disease, nausea and reflux may occur, and as the liver cysts grow, the abdominal girth increases.
Most patients I'll see complain of a distended abdomen, pain in the rib cage, early satiety, and they are unable to eat full meals. They have dyspnea, and some patients actually have problems in laying on their belly. So they move to the back or to the side when at sleep. Some 30% of the patients have abnormalities in the liver biochemistry. In particular, elevated alkaline phosphatase and elevated gamma-G can occur. These are not related to an underlying disorder, but related to the polycystic liver disease. A minority of patients have elevated CA 90.9. And this is a biomarker of cancer. In our patients, it's not indicative of cancer, but is completely related to the polycystic liver disease.
The most important method for diagnosing PLD is ultrasound. It can be used to monitor the course of disease and identify problematic cysts. In addition, CT and MRI examinations are indicated for special questions, for example, in preparation for therapeutic interventions or to measure the liver volume.
The most common complication that I see in patients is cyst bleeding. In these patients, actually, sudden abdominal pain develops, and that is due to the cyst bleeding. That pain will gradually decrease over the course of several days, and patients with cyst bleeding can be managed conservatively. Another problem that can arise is a cyst rupture, in particular if the size of the cyst is rather large. These patients can also be managed conservatively, and in those patients, ascites can arise as a result of the cyst rupture. Another complication is cyst infection, and this can arise in particular in patients with ADPKD and with multiple liver cysts. In these patients, they can present with abdominal pain, fever, and an acute phase reaction with an elevated CRP. Those patients need to be managed with antibiotics. And the last complication that can be seen is portal hypertension as a result of strategically located cysts. In particular, if cysts are close to the hepatic veins, where they can cause obstruction, and you have hepatic vein outlet obstruction syndrome.
If PLD is symptomatic and therapy is indicated, several interventional therapeutic options are available. One option for dominant cysts is aspiration sclerotherapy.
In particular, cysts that are larger than 8 centimeters are very well suited for this therapy. With aspiration sclerotherapy, you get the contents out of the cyst, you inject ethanol, and then you remove ethanol after some time. After the procedure, the volume of the cyst will decrease over time, and we know that after 60 days, the liver volume will have decreased appreciably.
An alternative surgical option in patients with polycystic liver disease and dominant cysts is laparoscopic fenestration.
This is a procedure where the surgeon actually cut off the dome of the cyst, and he can do so for multiple cysts in one procedure. While this procedure is quite effective, it is associated with morbidity, and recurrence can occur.
For localized disease, partial liver resection may be indicated.
It is a procedure that is not being done very often, needs very experienced hands, and can lead to considerable morbidity. But if successful, it leads to a large drop in liver volume. The option in patients with very severe polycystic liver disease with a compromised quality of life is liver transplantation. The outcome of liver transplantation is good, and 80% of the patients survive beyond 10 years. In patients with a lot of symptoms who do not fulfill the criteria for liver transplantation or any surgical therapy, drug therapy is actually an option. For that, we have somatostatin analogs. Somatostatin analogs are able to decrease the liver volume in patients with polycystic liver disease, and that is being associated with a decrease in symptoms in these patients. We treat patients either with octreotide or lanreotide, long-acting, with an injection every month. We follow up those patients with a CT scan, we do the volumetry, and we see whether the drug is actually effective. In some 60 to 70% of the patient, there is an appreciable drop in the liver volume.
But a diagnosis of PLD alone does not result in therapeutic procedures. Therapeutic procedures are only indicated in case of a symptomatic disease. Even hepatomegaly or large cysts do not have to be treated if there are no symptoms. And also in some of the complications, such as cyst bleeding or rupture, treatment is not warranted. All in all, PLD is a benign disease that may become symptomatic in a proportion of patients. In these cases, treatment options are available, which have to be selected carefully.
The most important determinant to treat patients with polycystic liver disease is their quality of life. And treatment should always be focused in maintaining the quality of life of these patients. And most physicians will see only 1 or 2 patients with polycystic liver disease during their lifetime. So expertise is actually needed. And ERN Rare Liver is able to connect doctors and to bring that expertise to the patients where it is needed most.